Your head hurts, but why does it hurt in so many different ways? Some headaches feel like a throbbing drumbeat, others like a vice grip, and some create a deep pressure behind your eyes. The difference lies in where the pain comes from and what it signals. Contrary to popular belief, the brain itself can't feel pain. The pain we associate with headaches comes from the nerves, blood vessels, and muscles around the skull, as well as the meninges, the brain's protective layers. When these tissues become inflamed, compressed, stretched, or irritated, your brain interprets these signals as pain. There are over 150 types of headaches, but in this series, we'll focus on the three most common and confusing. Tension-type headaches, a dull, squeezing pain on both sides of the head; sinus headaches, pressure or fullness in the face, often confused with migraines; migraines, throbbing, one-sided pain often with nausea, sensitivity to light, and sometimes aura. Each type is driven by distinct mechanisms and requires different treatments. Misdiagnosis is common, which means people are often treating the wrong headache and wondering why they don't feel better. So how can you tell which one's bothering you? If you've ever said, "I have a headache," chances are you were talking about a tension headache. It's the most common type, affecting up to 80% of adults at some point in their lives. And yet, despite how widespread it is, tension headache is often misunderstood or overlooked entirely. So what exactly does it feel like? Imagine a tight band wrapped around your forehead, or a dull, pressing pain that builds slowly throughout the day. Tension headaches are usually bilateral, meaning they affect both sides of the head, and are often described as pressure, heaviness, or a squeezing sensation. The pain is typically mild to moderate in intensity and not worsened by routine activity like walking or climbing stairs. Unlike migraines, tension headaches don't come with nausea, vomiting, or strong sensitivity to light and sound. You might feel a bit tired or irritable, but you'll usually still be able to function, just not very comfortably. What causes them? Tension-type headaches are often triggered by stress, poor posture, eye strain, dehydration, or lack of sleep. Think of long hours at a desk, staring at screens with slouched shoulders and clenched jaws. Over time, the muscles in your neck, shoulders, scalp, and jaw tighten, creating the tension that fuels the headache. There are two main categories. Episodic tension headaches happen occasionally, lasting 30 minutes to a few hours. Chronic tension headaches occur 15 or more days a month for at least 3 months. So how do you treat them? Start with lifestyle adjustments. Take regular screen breaks. Practice good posture. Stretch your neck and shoulder muscles daily. Stay hydrated and get enough sleep. For immediate relief, over-the-counter medications like acetaminophen or ibuprofen are effective, but they should be used sparingly, no more than 2 to 3 times a week, to avoid medication overuse headaches. You can also explore non-drug treatments, such as massage therapy, heat packs, stress management techniques, e.g., deep breathing, meditation, cognitive behavioral therapy, CBT, especially for chronic cases. Tension headaches may seem less serious than migraines, but when they're chronic, they can wear you down. If you're having frequent tension headaches, talk to your doctor about prevention strategies and check if there's an underlying muscular or stress-related cause. You feel pressure behind your eyes, your cheeks ache, your head feels heavy, especially when you bend forward. Naturally, you think, this must be a sinus headache. But here's the surprising truth. Most people who believe they have sinus headaches actually have migraines. So what is a real sinus headache? Sinus headaches are caused by inflammation or infection of the sinus cavities, the air-filled spaces in your forehead, cheeks, and behind your nose. When these spaces become blocked with mucus, usually due to an infection or allergy, pressure builds inside them, leading to pain. True sinus headaches typically come with other nasal or sinus symptoms, such as thick nasal discharge, yellow or green, facial swelling or tenderness, a reduced sense of smell, fever, ear fullness, pain that worsens when bending forward. In short, sinus headaches are secondary headaches, meaning they're the result of an underlying condition like sinusitis, sinus infection, or allergic rhinitis. But here's the catch. Studies show that up to 90% of sinus headaches diagnosed by patients are actually migraines. Why the confusion? Because migraine pain often includes facial pressure, nasal congestion, and watery eyes, especially when it affects the trigeminal nerve, which innervates the sinuses. These migraine symptoms can mimic sinus issues so well that even experienced doctors get fooled. So how do you tell the difference? Look for systemic signs. True sinus headache usually comes with fever, infection symptoms, and thick mucus. Migraine, by contrast, often includes throbbing, one-sided pain, nausea, sensitivity to light and sound, a history of recurring attacks, triggers like stress, certain foods, or hormonal shifts. The pain of sinus headache tends to be steady, dull, and located in the forehead, cheeks, or bridge of the nose, and often improves after antibiotic treatment if caused by bacterial infection. Migraine pain won't improve with antibiotics and is more likely to recur cyclically, regardless of weather or illness. Treatment for sinus headache focuses on clearing the infection or inflammation using nasal decongestants, antihistamines, saline rinses, antibiotics, if bacterial, inhaled corticosteroids for chronic sinusitis. If your facial pressure returns again and again, especially without fever or mucus, it's worth asking, could this be migraine in disguise? Numbness or tingling in the face or hands, speech difficulties. Rarely, muscle weakness or confusion. Aura usually develops gradually over 15-60 minutes and fades away before the headache fully kicks in. What causes migraine? We don't fully understand the cause, but migraine is believed to involve hyperexcitability of the brain, altered blood flow, and inflammatory changes in the nervous system. It often runs in families, suggesting a genetic component. Migraine attacks are triggered by a wide range of factors, including hormonal fluctuations, especially in women, stress or letdown after stress, changes in sleep pattern, certain foods, aged cheese, red wine, chocolate, caffeine changes, bright lights or strong smells, weather changes. Types of migraine include migraine with aura, classic migraine, migraine without aura, common migraine, chronic migraine, more than 15 headache days, month. Hemiplegic migraine involves temporary paralysis on one side. Vestibular migraine includes dizziness and balance issues. Diagnosis and treatment. Migraine is diagnosed clinically, meaning no blood test or scan can confirm it. A detailed history is key. Treatment falls into two categories. Acute, medications like triptans, NSAIDs, anti-nausea drugs. Preventive, daily meds, beta blockers, antidepressants, anticonvulsants, Botox, or CGRP inhibitors for those with frequent attacks. Non-pharmacological treatments like biofeedback, acupuncture, yoga, and lifestyle adjustments also play a vital role. If you find yourself in bed multiple times a month due to pounding head pain, nausea, and light sensitivity, this is not stress or sinuses. It's likely migraine, and it deserves real treatment. By now, you've seen that not all headaches are created equal. But in the moment, when pain hits, it's easy to get confused. Is this a migraine? Just tension? Or maybe something with my sinuses? To make sense of the symptoms, let's put the three most common types side by side. Migraine pain quality, throbbing or pulsating. Location, usually one-sided, but can shift or become bilateral. Intensity, moderate to severe duration, 4 to 72 hours. Associated symptoms, nausea or vomiting, sensitivity to light, sound, or smells. Aura, visual sensory changes in by 25% of cases. Triggers, hormones, stress, sleep changes, certain foods, weather aggravated by movement. Yes. Treatment, triptans, NSAIDs, anti-nausea meds, preventives, tension, headache, pain quality, dull, aching, tight pressure. Location, bilateral, both sides, often forehead or back of head. Intensity, mild to moderate duration, 30 minutes to several hours. Associated symptoms, muscle tenderness in neck, scalp, no nausea or vomiting. Mild sensitivity to light or noise only, not both. Triggers, stress, posture, fatigue, eye strain. Aggravated by movement? No treatment. OTC pain meds, stress reduction, posture correction, sinus headache pain. Quality, deep, constant pressure. Location, forehead, cheeks, nose bridge, around eyes. Intensity, mild to moderate duration, until infection clears, can last days. Associated symptoms, nasal congestion or discharge, yellow-green. Fever, facial swelling, pain worsens when bending forward. Triggers, sinus infections, allergies. Aggravated by movement? Yes, especially bending or lying down. Treatment, decongestants, antibiotics, if bacterial, sinus rinse. Key differences, if you have nausea, plus light sensitivity, think migraine. If you have facial pain, plus thick nasal mucus, plus fever, likely sinus. If it feels like a band tightening around your head, no nausea, and comes with stress, likely tension. If pain comes in episodes, with triggers and hangover feeling after, probably migraine. Many people misdiagnose themselves. One of the most common examples? Thinking a migraine is a sinus headache, especially when there's eye tearing and congestion involved. But unless you have fever or colored nasal discharge, sinus is less likely than it seems. Understanding these patterns is crucial not just for relief, but for finding the right treatment and preventing future episodes. When you visit a doctor for headache issues, you might expect tests, scans, or blood work. But here's the surprising truth. Most headaches are diagnosed without any imaging at all. Instead, your story, what you say, how you say it, and what patterns you describe, carries the most weight. Unlike other medical conditions where lab tests confirm a diagnosis, headaches are clinical syndromes, meaning they're defined by patterns of symptoms. That's why doctors spend more time asking questions than ordering MRIs. So what will they ask? Expect questions like, when did your headaches start? How often do they occur? How long do they last? Where is the pain located? What does the pain feel like? Throbbing, stabbing, squeezing. Do you experience nausea, visual changes, sensitivity to light or sound? Do certain activities, foods, or stress trigger it? Is there any family history of headaches or migraines? Your answers to these help build a diagnostic picture. For example, pain that's pulsating, one-sided, with nausea, likely migraine. Pressure pain, no nausea, comes after long days at the desk. Likely tension, facial pressure with fever and thick mucus. Likely sinus headache. What about tests? Doctors only order imaging, like CT scans or MRIs, if they suspect something unusual or dangerous, such as sudden, severe headache, thunderclap pain, new headaches in patients over age 50, headaches with seizures or neurological symptoms, confusion, weakness, speech issues, headaches that wake you up from sleep, or worsen with coughing, progressive pattern, with no clear cause. These could signal secondary headaches caused by tumors, bleeding, or structural problems in the brain. But for the vast majority of patients, no such cause exists, and tests come back normal. Keep a headache diary. One of the best tools you can bring to your doctor is a simple headache diary. It should include date and time of headache, duration, pain description, location, severity, triggers, sleep, stress, foods, medications taken and response, additional symptoms, nausea, aura, etc. This log can help your doctor see patterns you may not notice and tailor treatment accordingly. Remember, your experience matters. No one else feels what you feel. The better you describe your pain, the better chance your doctor has of targeting the right cause. Let's break it down by headache type and treatment category, from quick relief to long-term prevention. Migraine acute, rescue treatments. Triptans, like sumatriptan. First-line therapy for moderate to severe migraine. Work best when taken early in the attack. NSAIDs, ibuprofen, naproxen. Often effective, especially if taken at onset. Anti-nausea meds, metoclopramide, ondansetron. Help with GI symptoms and can improve absorption of other drugs. Gepants, ubrogepant, rimegepant. Newer migraine-specific options for those who can't take triptans. Preventive treatments. For those with frequent migraines, 4+ days, month, Doctors may recommend beta blockers, propranolol, anti-seizure meds, topiramate, antidepressants, amitriptyline, venlafaxine, Botox injections for chronic migraine, CGRP inhibitors, Imovig, Emgality, Ajovy, monthly injections that reduce frequency, lifestyle changes, sleep, diet, stress management, tension headache, acute treatments, OTC pain relievers, acetaminophen, ibuprofen, aspirin, caffeine, small doses, e.g. in Excedrin, can boost effectiveness. Heat therapy, warm compresses on the neck, shoulders can relax tight muscles. Massage or gentle stretching. Preventive options, CBT, cognitive behavioral therapy, for stress reduction. Biofeedback, exercise and posture correction. Low-dose tricyclic antidepressants, for chronic tension headache. Sinus headache, if caused by infection. Decongestants, pseudoephedrine, oxymetazoline nasal spray. Nasal corticosteroids, fluticasone, mometasone. Saline rinses, neti pot. Antibiotics, only if bacterial sinusitis is confirmed, fever plus colored discharge. Steam inhalation and hydration. If allergy-related, antihistamines, cetirizine, loratadine. Allergy avoidance immunotherapy, allergy shots. Medication overuse headache, MOH. One major pitfall, using acute meds too often, especially NSAIDs or triptans more than 10-15 days, month. This can lead to rebound headaches. If this happens, your doctor may stop all acute meds for a period and start a preventive regimen instead. Alternative therapies. That may help: acupuncture, yoga and meditation, riboflavin, vitamin B2, magnesium, CoQ10, neuromodulation devices, cephaly, gamma core. Most headaches, even when painful or persistent, aren't signs of anything dangerous, but some are. And in those rare cases, recognizing warning signs early can be life-saving. So how do you know when to stop self-treating and see a neurologist or headache specialist? Let's start with the red flags, also known as secondary headache warning signs. Red flags. Seek immediate medical attention. If you experience sudden severe headache, often described as the worst headache of my life. This could be a subarachnoid hemorrhage, bleeding in the brain. New headache after age 50 could indicate temporal arteritis or a brain mass. Headache with fever, stiff neck, confusion, or seizure may point to meningitis, encephalitis, or other infections. Headache after head trauma, especially if it worsens or includes confusion, vomiting, or drowsiness. Progressive headaches, worsening over weeks, unresponsive to meds. Visual loss, speech difficulty, or weakness on one side could signal stroke, tumor, or vascular issues. Headache that wakes you from sleep or is worse in the morning. Possible sign of increased intracranial pressure. Chronic headache, time to see a specialist. Even if your headache isn't dangerous, you may still benefit from specialized care if you have 4 or more headache days per month. You've tried multiple treatments without success. Your headaches are disrupting work, school, or personal life. You suspect medication overuse or rebound effects. You're unsure if it's migraine, tension, or something else. You have other neurological symptoms like vertigo, tingling, or visual changes. Neurologists or certified headache specialists can refine your diagnosis, explore advanced treatments like Botox or CGRP inhibitors, recommend preventive strategies, order imaging if necessary, rule out rare but serious causes. How to prepare for your visit. Bring a headache diary, including frequency and duration, pain description and location, triggers and patterns, medications tried and response impact on daily life. Be ready to discuss your family history, lifestyle, and any past scans or labs. Many patients delay seeing a specialist because they normalize their pain or fear being dismissed. But the reality is, if your headaches affect your quality of life, you deserve expert help. It starts with building a personalized game plan, a blend of self-awareness, prevention, and smart response. 1. Track your triggers. Knowledge is power. Use a headache diary or app to identify foods or drinks, caffeine, wine, aged cheese, etc., sleep habits, hormonal cycles, especially in women, stressful days versus relaxed days, weather shifts, especially barometric pressure drops, screen time or eye strain. Over time, you'll notice patterns. Even small changes, like staying hydrated, adjusting your lighting, or setting a regular sleep schedule, can lower your risk of attack. 2. Build a headache toolkit. Think of it like a first aid kit for your brain. Include your most effective pain relievers with doctor guidance, cold or warm compresses, noise-canceling headphones or sunglasses, a dark, quiet recovery space, aromatherapy, peppermint or lavender may help some people, ginger or anti-nausea aids. Knowing you have a plan helps reduce anxiety, and that alone can lower headache frequency. 3. Strengthen your defense with daily habits. Headache prevention often lies in consistency. Try to wake up and sleep at the same time each day. Avoid skipping meals. Exercise regularly. Even walking helps. Practice stress reduction techniques, meditation, yoga, journaling. Limit overuse of OTC medications, less than 10 days, month. If you need preventive medications, stick to them daily, even when you feel well. Preventive care is a long game. 4. Build a support network. You're not alone. Millions deal with chronic headaches. Consider talking openly with your employer or teachers, joining a support group or online community, involving close family or partners in your care plan, seeking therapy. If headaches affect your mood or relationships, pain is isolating, but connection is healing. 5. Reassess regularly. What worked 6 months ago might not work now. Life changes, hormones shift, stress levels rise and fall. Review your plan with a doctor every 6 to 12 months and adjust as needed. Final thought. Living with headaches isn't about powering through. It's about understanding your unique patterns, getting the care you deserve, and treating yourself with compassion. Pain may be part of your life, but it doesn't have to define it. You are not your headache, and you are not alone in this fight.